These projects are always a partnership. We have health infrastructure, of course, but the local health district, in this case Hunter New England, plays a very strong role in terms of the progression of the project, and we want to involve the frontline clinical staff. We want to involve our patients, and we want to involve our carers. We want to involve our Aboriginal communities in getting into the nitty-gritty of designing these spaces. Our health architects primarily design spaces around the clinical requirements, the technical requirements. Where's the pendant? Where are the gases? How much room do you need around a patient's bed to resuscitate them? Which is all well and good, and we need to address that. But we often miss the opportunity to create a space which evokes positive emotional reaction in our patients. So what we've done here at Hunter New England is we've developed our own process for that, which we call emotional design briefs. And what we do is we interview patients, carers, and our staff and understand what are the positive and negative emotions they're feeling in our current spaces. And then we document that. And then we ask our architects to take that information and really put in detailed effort in designing spaces that address those negative emotions, try to rein them in and really promote positive emotions. So we've built this prototype room in a vacant space that we had outside of the John Hunter Hospital. It gives the ability of our patients to come and assess it from a physical perspective, from an ambience perspective, but importantly it also gives our clinical staff the ability to come and test the space from a clinical emergency response perspective, which is really important, but also from a day-to-day perspective in terms of helping a patient in and out of the bedroom, helping them go to the bathroom, and the day-to-day interactions that you have with a patient.
I'm one of the anaesthetic fellows, and I also have a role in simulation and education this year, which is how I became involved in all of this. So the team down there are largely comprised of critical care nurses and doctors, so ICU nurses, anaesthetic nurses, and a lot of the consultants involved are from the anaesthetic department, but draw from a lot of the critical care areas, so ED and ICU as well. So we're sitting in the prototyping area for the new hospital, so with prototypes of the new room. So we first did a couple of sims in the old room just to get a feel for how things would work there. It's not my usual work environment on the ward, so it was good to get a sense of what that felt like. And then we ran the scenario again in the new room just to see what the differences were and to see what the impact of the room was on just physically doing what you needed to do for the patient. I think the fact that we've been able to be involved at this stage where you can identify those issues and you can flag things that won't work in the clinical environment means that the changes are going to be made before it's then implemented and the new hospital's built. If we weren't involved at this stage, it's too late, isn't it? So I think it just gives you confidence that the consultation is being done and that it's appropriate and that hopefully we'll have the outcome of making it a better, more usable space.